Nós hoje temos David Rhew, é médico, é Chief Medical Officer da Microsoft e vice-presidente também para a área de serviços de saúde. Ele vai-nos falar de Digital Health World Challenge. Essencialmente vai-nos falar como é que os sistemas de informação nos apoiaram a lidar com a Covid-19 e vai-nos falar também como é que estes sistemas de informação, estas tecnologias nos vão apoiar a transformar o sistema. Espero que para todos seja muito impressiva e inspiradora esta conferência. David, thank you so much for being with us. I did this brief presentation in Portuguese. Most of our audience is Portuguese. I was just presenting you as Chief Medical Officer and VP of Healthcare for Microsoft, and saying that you are going to address different topics, mostly related how technology helped us in the last 10 months and how technology will help us in transforming health systems. I believe that you are going to do this presentation, and afterwards we can have a short conversation about the impact of technology in the healthcare. Thank you so much for being with us, and the floor is yours.
Thank you, Alexander, and hello everyone. Real pleasure to be here. My apologies, I'm going to have to give this presentation in English, so hopefully I'll be able to articulate things in a way that will be understandable and allow you to be able to see, hopefully, the opportunities that may exist that we are seeing in the United States and globally that would also have relevance to your current practice. But by way of background, my name is David Rhew. I am the Global Chief Medical Officer for Microsoft, and I'm a physician. I'm a healthcare informaticist, one who spent a lot of time thinking about technology and looking at how technology can be used to improve health outcomes, specifically access to care, quality of care, ways to improve the efficiency of care, remove waste from the system, improve the physician and clinician experience, and most importantly, the patient experience. And in that journey that I've had over the past 25 years, it has taken me to different places, different companies, in different parts of the world. And what I first started, it was in the early days of electronic health records when EHRs were starting to become much more popular. There was legislation in the United States that was mandating the use of EHRs. And during this time period, we saw a digital transformation of medical records. But at the same time, clinical workflows were traditionally on paper and pen or pencil. Now what we were looking at was digitizing many aspects of that, and also allowing us to be able to understand what could be done within the context of a digitized record. As most of you know, we have now embarked on that journey, and we can do a lot of things. We can potentially exchange information a little bit more freely, but there are still barriers. We can apply clinical decision support, but sometimes the information is in formats that doesn't allow us to be able to understand all the inputs and coordinate and collaborate in ways that allow us to be much more efficient. And so as I started down that journey, we realized there was a lot of work that needed to be done to build out these systems and implement it. But the broader goal of improving outcomes and access to care would require that we involve the patient and their families. In order to do so, one of the things that we have started looking at and now has become, I'd say, more of a movement is consumerization, patient-centered care, understanding how the patient can be at the center and enable a lot of the care to be directed, giving the right information at the right time to not only the provider, but also to the patient and their family, so they can make smarter, more informed decisions. And ultimately, that movement from a technology perspective became pretty clear to me and others that were thinking about this at the time, that we needed to have a different type of platform to support clinical workflows as well as patient workflows, patient lifestyle. And patients don't typically go into electronic health records or even patient portals on a regular basis, But what they do use is they use smartphones, they use now smart watches, they have sensors that are embedded throughout multiple different technologies. They will, in many ways, be using these every single day, if not every hour. And what we find is that we are able, in many ways, to harness that type of technology and be able to direct that to better health outcomes. So a good example would be some of the work that I did when I was Chief Medical Officer at Samsung, and we embarked on projects related to the use of virtual reality to address pain management, where we did a randomized control trial and demonstrated a 50% reduction in pain using virtual reality to basically treat patients that had moderate to severe pain. We also did a study, and it became really more of a, I'd say, an opportunity for us to understand how we can transform the entire digital experience for patients and providers. So much of virtual care today, which we see in the form of telemedicine, was really just a starting point, and it is just a starting point. What we've recognized is that there's so many ways that we can virtualize care. One of the projects that we worked on at Kaiser Permanente, large IDN based out of the California area, but really has expanded throughout the United States and multiple states, is if we took patients who have just had a heart attack and looked at what typically happens to them, they're asked to undergo a cardiac rehabilitation program, which can be 6 to 8 weeks. This is a program that requires them to come into a facility, exercise for maybe 45 minutes to an hour, and then do this consistently for 6 to 8 weeks. And the value of doing that is tremendous. In fact, the number needed to treat to save one life is anywhere between 7 and 17 patients. So that means that for every 7 to 17 patients that complete these programs, you're saving one life. An incredibly important program. But at the same time, the nationwide rates of completion for these programs is less than 50%. In fact, at Kaiser Permanente, it was 42%. And what we realized was that we were making it difficult for patients because patients were ultimately needing to take time off from work, find someone to take care of the kids, maybe even lose an opportunity to do certain things that were important to them. This was something that where lifestyle and the current needs of the patient overwhelmed and superseded the benefits that they could achieve from doing the healthcare rehabilitation. So what we found was that if we could take that program and we could virtualize that onto a device like a smartwatch and just simply ask the patient, you have a choice. You can either come in for 6 to 8 weeks or and do this for three times a week for an extended period of time, or we can just ask you to wear a smartwatch and just exercise when it prompts you to. And what we'll do is we'll record that exercise, we'll do a cool down period, and then we'll ask you if you have any symptoms. Well, that one program, when we reviewed it with the cardiologist, they said, just add a medication reminders and an ability for them to be able to reach out to us if they have any questions or concerns. And you've got our program, our cardiac rehab program, virtualized. We gave that choice, and a large number of patients adopted it. And what we saw was that we found a near doubling of the completion rate from around 40% to well around 80%. And what that allowed us to be able to understand was that we could actually improve not only adherence to this program, but when we measured the readmission rate to the hospitals for this particular group of patients, we saw a reduction from around 12% to less than 1%. So ultimately, this program has now been scaled beyond the initial 200 patients to 1,200 to now across all of Kaiser Permanente. It's an extraordinary example because it gives us some insights where healthcare is going. It's going towards virtualized care, digitized care, patient-centric care, which will lead to increased access to care, better quality, and lower costs. And what we've done in many ways in creating these systems has enabled us to rethink what's possible. But one of the challenges that's emerged, and it continues to be a problem across the entire healthcare ecosystem, is that data tends to be siloed. It tends to be siloed into different systems of record. And so I mentioned the first part of my career being in electronic health records. Well, much of that data was locked in EHRs. And as long as you worked within an EHR setting or a hospital that used that same EHR, you had access to the tools that allowed you to be able to do many things. But as soon as you were to, let's say, move or potentially need to be hospitalized at another facility and they needed to gain access to those records, perhaps maybe it's a COVID situation where there's an influx of patients coming into the hospitals and not all of them are being managed by that hospital or on that electronic health record, then in that scenario, that ability to gather information in many ways goes back to the old paper and pencil. And what we're realizing is that that is not really an opportunity for us to be able to leverage technology because of these silos. Similarly, when we looked, even with the success of the virtualization programs that I've talked about, all the data was locked. It was locked on the devices. It was locked in different proprietary systems. And what we want to do is we want to be able to combine all that data together. We want to be able to combine electronic health record data with data from the patient's lifestyle, the biometrics that we're gathering from devices. It turns out that when you look at overall health outcomes, about 20% of one's healthcare is based on the EHR data that we collect today, while about 80% of that is based on all the other factors, including lifestyle, biometrics, sleep, stress, social determinants, and social influencers of health. What I mean by that are things such as your socioeconomic situation, the crime and the education in your area, the ability for you to be able to access food, housing. All of those are factors that have a direct impact on your ability to take care of yourself and ultimately your health. And if we want to understand a patient holistically, all those pieces of data need to be brought in specifically into a common platform through interoperability and allow us to be able to exchange that in ways that we haven't done, but most importantly, once it's brought into a platform, apply artificial intelligence, machine learning, draw insights from them, and become much more proactive. And that's where we're heading right now for healthcare. We are on this journey where many of these systems that we have built that are now being adopted are starting to become much more liquid in the data format. And by pulling the data into these common platforms, we can then enable better and more coordinated care. Which brings me to my journey towards Microsoft, because Microsoft is on that journey to help organizations bring this information together and support them in ways that they'll allow them to be able to achieve their goals. And Microsoft, many of you know Microsoft for the software technologies and perhaps even some of the hardware technologies that we've offered. Early on, we had a mission, and the mission was very technology focused. It was technology focused. I think it was something to the extent of putting a computer on every single desktop. Well, over the past decade, that technology-driven mission has transformed to one that is much more relevant to healthcare, and that's about empowerment. It's about empowering individuals, families, caregivers, healthcare providers, healthcare organizations to be able to achieve their goals through technology and be able to do more than what they can currently do. And that is something that has allowed us, by repositioning our mission, to define new platforms and new technologies, many of which I'll share with you today, that will allow us to be able to rethink what's possible. And in so doing, create a common cloud platform that pulls data from these different data sets, allows us to apply AI, and then do a level of care coordination and communication to be able to deliver better care. And as part of that journey, what we have found is that much of what our goal over the past many months has changed. And it's changed in ways that were unpredictable. What we found is that much of the care that we were delivering when COVID hit, it hit and affected not only every one of our lives, but the entire focus for where healthcare needed to be. Let me start with some examples. And one of the things that I didn't share, but is also relevant to the story, is that I am not only a physician, but I'm also an infectious disease doc. I trained at, during the era in which AIDS was very common. And I saw during that time period how epidemics could be managed and some of the best practices and things that we could do as a global community. Well, fast forward to 2020, where we now have another epidemic, this time a pandemic with another virus that is causing great amount of trauma and economic ruin across the globe. What we're finding is that this virus, when it first hit into the major cities and the smaller cities, the number one thing that was the issue was patients and family members and other individuals wanted to know, do I need to come into the hospital? Where do I need to go? And this allowed us to be able to think through how potentially some of the technologies could be used to help address the issues. And what you see on this slide here is our 6 categories of how technology has been applied over the past 10 months to be able to help us better manage the challenges that have arisen because of COVID-19. And this has allowed us in some ways to even accelerate some of that digital transformation that I was talking about before, and allow us to be able to sort of, in many ways, rethink what's possible. So back to the story of when COVID first hit, it actually in the United States hit a nursing home in Kirkland, Washington, which is very close to Seattle. It turns out that in that area, there's a very large health system called Providence Health System. And there's a company, Microsoft, that is based out of there. And turns out that Microsoft and Providence are strategic partners. So when Providence started experiencing many of the challenges related to the number of patients that were calling, and actually were finding difficulty even getting through, they were coming into the emergency rooms, the urgent care centers, and in a lot of the scenarios, because they weren't getting the answers right away, they were sitting next to people potentially who could be infectious. And that was just further spreading the infection. And so what we wanted and needed to do was we needed a mechanism to answer those questions at scale, at a population level, using standardized evidence-based protocols, and allow patients to be able to know what to do with a very individualized response. I mean, simply having, here are the recommendations in a website didn't give enough information and specificity for patients. They'd be like, but I just recently traveled, I have these symptoms, what do I need to do? And so what we found is that a chatbot, an AI-based chatbot, could actually take the exact specific questions that need to be asked, allow us to be able to run it through the algorithms, and then generate a response that would allow us to be able to give direction. And what happened was almost immediately when we deployed that, we converted it to a COVID-19 chatbot. We saw about a 30 to 40% reduction in call volumes. And that was then followed by a subsequent decrease in foot traffic to ERs and urgent cares. It allowed healthcare organizations on the initial influx of patients to be able to better manage that flow because they now were able to focus on the sicker patients and not having to do all the triage up front. Additionally, once the patients that were identified who actually needed to have further assistance, these are perhaps patients who are symptomatic or had recent exposures, those are individuals that should be isolated and staying at home, or in some cases brought to the hospital for evaluation. In some cases, testing would be a critical component of this. So the need for us to be able to then do that handoff from an AI-based screening bot, which could be on your mobile phone or a website, to then hand that off to a virtual care visit, was something that we also had to do, and that level of integration has enabled us to be able to have both a screening and triage system that was virtualized. And in that process, there was an opportunity to understand that these individuals potentially could be eligible based on symptoms and other parts of their journey for clinical trials and potentially even donors. One of the things that we've been looking at is the use of convalescent plasma. Could that be helpful for certain subgroups? Perhaps even donating to create immune globulins around this, and allowing us to be able to sort of rethink what the possibilities of using a chatbot are for frontline workers. And this entire category of chatbot has become one of the major success stories throughout not just our experience in Kirkland and in the Seattle area, but it has since then been adopted globally. And I'll share with you some stories shortly, specific around across the globe how it's being used. But just to give you some statistics, over 25 countries have adopted it and over 600 million messages. We're talking over 500 million messages delivered to help individuals triage. So an incredible success story, one that came about really because of the need to provide urgent and more individualized information. But I mentioned this concept of chatbots handing off to a virtualized environment. This is something that also emerged as an important component of our response to COVID. While patients were being asked to stay at home, businesses, including hospitals and clinics, were also being asked to limit the number of people that could come in and potentially initially shut down. And that meant that as much as possible, we would need to try virtual care predominantly in the form of telemedicine, but now looking beyond telemedicine to other aspects. And what we found is that simply providing a video consultation isn't quite sufficient. We need, first of all, HIPAA compliance, or like the patient security around how the conversation will be captured. We need to make sure that there's a natural ability to do bookings online, create these what we'll call waiting rooms for patients, allow us to be able to understand how this can pull data from the medical record. So during a visit, we can actually see lab results and x-rays and collaborate with our patients on this. And as part of that journey, one of the things we realized is that once we build that capability to pull data from the electronic health record and share that within a viewing environment, such as Teams, which is a collaboration tool that we offer, by enabling that through something called a FHIR API, we were able to then rethink and reimagine what those possibilities of different use cases are. And that allowed us to then move towards the point of what else can we bring in and combine and make virtual. Virtualization of ICUs was one important area. When we first were hit with the major COVID crises in areas of the United States, such as New York early on, the number of patients that were coming in was overwhelming the system. And these patients were sick. They were coming into the ICU. They were requiring ventilation. And in fact, in many cases, we were running out of ventilators and we were running out of specialists to be able to take care of those patients on ventilators. What we needed was, in some ways, one or a group of people who were trained who could then manage multiple patients virtually. And that process allowed us to rethink how virtual ICUs could be deployed. Working closely with one of our partners, GE Healthcare, we, within a matter of 2 weeks, took some technologies that were being developed for an on-prem solution and converted it to a cloud solution to make it nimble so clients could actually stand these up within a matter of days to weeks as opposed to months in terms of creating new servers, and allowed us to be able to then implement technologies that could pull data from different systems within the electronic health, within the ICU setting, such as the electronic health record, ventilators, drips, and allow for a single dashboard or a single screen so individuals can manage multiple different patients. This was also another big victory because it decreased the amount of exposure that clinicians were having, increased our access to trained specialists to larger number of patients across the board, and also was something that was helpful in terms of decreasing PPE, personal protective equipment. So really 3 major benefits for this. And what we found is that that was another key learning that allowed us to be able to sort of rethink the clinical workflows. Another was once we were able to think about how using teams with ability to pull using FHIR APIs, pull electronic health record data into the systems of record, right, from the systems of record into the care collaboration platforms, we could do things that we had always done in person and on whiteboards or on paper, and do this virtually. And things such as rounding on patients. We could now pull, using a patient list, the entire list of patients that were on a floor, see and basically go through and pull up their records, pull up the x-rays, create tasks, have a bunch of people virtually collaborate and share information. So this virtual rounding for care teams seeing patients was one very impressive use case. We see sign-outs all the time. We work in shifts in many ways, whether they're ER shifts, whether they're nursing shifts, there are shifts that constantly occur from day to night. And that handoff from the patient load from this shift to the next, what the tasks are that need to be done, and even the ability for us to be able to show in the communication of this is the patient who has this type of an x-ray. You can show that now in that sign-out process. All of that was enabled. We saw ability to do consultation, some of the work that we did with the HoloLens, and I'll share an example of that, where the use of the HoloLens became not only a mechanism to provide a fantastic view, a three-dimensional augmented reality view of the actual viewing environment, but also allow us to be able to enable collaboration and coordination where you can have experts from around the country or the world collaborate with you, see exactly what you're seeing, pull up the x-ray information, and be able to manage the patient in collaboration and coordination with you. What we found is that this could then be applied into surgeries. And in fact, one of the projects that we've implemented is with use of 5G and in a surgical setting in the VA in the United States, the Veterans Administration, where we're now looking to see where surgeons can come in using a mixed reality, a HoloLens, and then that ability to pull information from the medical record, to be able to visualize this and share that with the team behind you. And then also our goal is to be able to see if we can apply artificial intelligence on the viewing field and be able to provide, we'll call it a GPS, a global positioning system, guidance system for the surgeons. A tremendous opportunity for us to bring surgeons who are either junior in training or doing a complicated surgery that requires a higher level of expertise to be able to expand access to care. And one other use case was around tumor boards. We had seen this before, but we recognized that a lot of times we do need to sit down and just have a comprehensive discussion around a patient and their care. It could be around cancer care, it could be end of life. But what we've realized is that can also be greatly facilitated through these virtual tools. So a lot of learnings in terms of how virtual care, not only what it could be done, but it accelerated during the pandemic because of the need to virtualize almost everything. And then what we were also, as I mentioned before, the need for us to take that information and start putting it together and drawing insights from it, allowing us to be able to use supercomputers and the cloud infrastructure so that we can pull data at any particular time and provide those immediate types of assessments. Gave us an opportunity to do modeling for the vaccines, potentially drugs, and of course, just the overall journey that the patient, that we all undergo if and when we were to be infected. What we've learned is that COVID is not just an infection; it is something that causes, in many ways, a different response for individuals immunologically. And so now looking at how an individual, when presented with the viral antigen, mounts an immune response, what the T cell receptors, whether there's active binding, whether there's an immune, a hyperimmune response, such as use of immunoglobulins or innate immunoglobulins or T cell killer cells. What is happening? Why is it that some patients respond in some way and others respond differently? And in many ways, trying to do this in the absence of supercomputers, in the absence of AI, in the absence of cloud, is nearly impossible. There's so many variations and possibilities. And so this has given us new hope and opportunity in terms of understanding the immune process and how we can then better develop drugs and vaccines for them. And then as we've been thinking through this process, one of the bigger requirements was that we needed to start sharing information at the most basic level. Where is the PPE? Where are the ventilators? How can we allocate who needs it the most? Are there opportunities for us to look at who's got the highest mortality? What about tests? Test kits, who has them? What's your test positivity rate? All of that information is something that needed to be centralized. It needed to be centrally managed, and ultimately the interoperability of data set systems, not just within healthcare, but within public health, needed to be upgraded. And large part of this was done on the fly with coalitions, but really significant opportunities for us to improve on a go-forward basis. A big area of interest has also been around the area of contact tracing and potentially the use of mobile applications and operating systems to do more automated management of patients. And what we sometimes lose track of is that contact tracing is a historically proven benefit that can be done on paper and pencil in just a simple conversation. The problem that we've run into is that it's inefficient, and we want to be able to make technology an enabler for that. So one of the first areas that we started recognizing is that if you're a contact tracer and you're trying to gather all this information and you've learned a lot of really good information on a patient, rather than you just contacting all your fellow contact tracers and letting them know, wouldn't it be great if you could actually have that into a system where all your fellow contact tracers would then be able to then activate and know that, oh, by the way, this person was in this area, and this is someone else that you need to be able to be aware of and contacting other individuals. This whole case management and the coordination between case manager or the contact tracers can be automated, and we've seen some great technologies developed in that capacity. If you're a person who's being asked to develop contact or to ask were you exposed to, it's hard to remember all that. And so these assist tools, like if I could pull up from my phone and just be able to say, over the past 5 days, who did I talk to? Where did I go? What were the addresses? What were the phone numbers? And have that all downloaded onto a spreadsheet where I could even use it for my own personal reference, or I could share that with the contact tracer if I felt comfortable. These are memory assist tools that also were and have been particularly valuable. And then, of course, the proximity awareness elements. So, as I mentioned, with the operating systems on the iOS and the Android systems, we now have an ability to potentially enable that, so long as people opt in and are willing to allow for that level of notification that, hey, I want to know if others around me have been exposed and vice versa. And what we're now heading towards is this new frontier. We've done many of these first 5 categories, perhaps maybe not as well as we would like to have, but we have been on that journey. We're now at the point where we're starting to look at the development of new tests and figure out how these tests can be done in a better way, in a more efficient, more patient-centric way. And what I mean by that is rather than having the individual, perhaps maybe in a drive-through or in a clinic, do this procedure, which places the swab deep back within your nose and perhaps causes you to gag and maybe cough some more. You do it at home with a swab just on the top tip of your nose, your nares. And it's something that could be done in not only the privacy of your home, but also give you results rather quickly instead of waiting for days, potentially even over a week, which makes it completely useless in most cases, to something that could be delivered within minutes. This is where we're heading with the technologies. It's a tremendous opportunity to start rethinking how we test larger populations. We can now start thinking of how potentially we can start doing baseline testing for organizations that are specifically frontline workers and people that are needing to get back to the workplace, perhaps even schools, and then thinking about how strategies can be applied on an ongoing basis beyond that. What we've now been thinking about is this whole return to work, return to school, return to life. In that capacity, it's not just about testing, but it's also about symptom attestation. Do you have symptoms that are consistent and worrisome for COVID? And if so, you shouldn't be coming in, and you should be aware that having loss of smell is a symptom, and that means that you should not be coming in. But sometimes you just need to be reminded, and you need to attest, and that attestation can be enabled through mobile applications. And lastly, the vaccine, and I'm going to talk a little bit more about that. significant amount of effort underway to try to improve the vaccine distribution. So as I've shared, I'm just going to share with you a few anecdotes relative to the things I've talked about. Many countries across the globe leveraging the use of bots to fight COVID. You can see in this slide across Europe, we've had many examples, even in Portugal, great examples. But what we have highlighted here are just numerous organizations, countries that have found that the bot can help with the triage, screening, and also achieve those similar benefits, which I shared earlier. One of the things that was done in the National Health Services, Imperial College in the UK, I mentioned the use of HoloLens, I mentioned the use of virtual rounding, combining those two into an ability where a clinician could walk into the room of a patient that's infected with COVID and have that conversation with them, and behind them, the entire care team is watching and providing information. You can see on the lower screen, you've got the patient, you've got the consultant on the left-hand side, and you've got the x-ray from that patient, all in that single view. What this allowed us to be able to do was to reduce the exposure by almost 51%. What we found is that was an important part of the value, in addition to being able to provide coordinated care. And then also the use of PPE, only one person's donning the PPE, and it decreased PPE usage by 83%. So some real benefits here that we achieved, and in a really innovative use case around virtual rounding. One of the things I mentioned also was the T-cell immune response. Some of the work that we've been doing relative to this has been in the context of work that we're doing with a company called Adaptive Biotechnologies. Adaptive Biotechnologies has been doing this for quite some time, but when COVID hit, they sort of repositioned some of their technologies to allow us to better understand the T-cell response to the COVID-19 antigens. And you can see it involves start taking blood samples from individuals, immunosequencing them, then applying that cloud-based machine learning on the system, all the different things that we're seeing from the T-cell antigen response, and then mapping that all out and understanding what's happened to different people and looking for patterns and trying to predict opportunities where we might be able to intervene. So significant amount of learnings in that. We talked about return to work and return to school. Well, there are now platforms, technology platforms that can help us enable a more efficient and streamlined approach. It's a little bit of a complicated picture on the right-hand side, so I'll simplify it down to, if you think of that flower as a clock, at the 9 o'clock, the employee app, the employee can then, and this could be also a student, can then every day check in on the app, and it will ask you the symptoms. You have any of these symptoms, any exposures, etc. You say no, and then you go to work or you go to school, which then goes to the 6 o'clock area, the employee care management. There's another app that the employer has that can scan in the patient. Just simply you show your phone, it's got a barcode, it scans it in. It's also been integrated directly into the systems, such as areas where patients have a badge scanner, or there's some other mechanism for them, a turnstile, and it allows them to be able to then automate that process. We've also seen, if you go to the 3 o'clock, that these buildings themselves, we could enable them to enable sort of more efficient ways to manage the overall processes, everything from ventilation to organization and of how things, the flow of patients and visitors throughout the facility, to things such as proximity awareness. So if a person badges in every day and out, can we use that information potentially to, if a person were to be infected, to know who's been in those areas during that same time period. And the dashboarding was really the key. While all of these technologies are helpful, there needs to be some oversight looking at each facility, how each facility is doing relative to the overall adoption of these tools, and also whether or not across larger systems, if there's certain areas that are hotspots where perhaps maybe there needs to be interventions on whether you'll implement stricter guidance and rules. So these are all technology enabled capabilities that we have seen deployed to help enable a return to work, return to school, return to life. One of the other areas that we've seen is the development of platforms to help support a potential vaccine. Today, there are over 11 types of vaccines that are in stage 3 or phase 3 for COVID-19 globally. Within each country, there's a smaller subset that will probably be launched. And while none has yet been proven, what we're recognizing is that we need to plan ahead for the time in which we will have a vaccine. And this is going to require more than just simply leveraging our existing system. The complexities of this are tremendous. First off, depending on the vaccine, there might be a booster shot that the individual will need to get. Secondly, some will need to be frozen, some don't need to be frozen. There's a certain amount of time that is required before it expires and you'll have wasted vaccine. You have to know exactly which patient you're delivering this to, because this is going to need to be tracked, and you're going to need to know if a patient actually has symptoms or they had certain side effects from this. These are all experimental vaccines still, so there's going to need to be an ability for us to track all of that. And then there's this whole coordination across the system, whether from distribution, from the pharmaceutical company, manufacturing, to the distribution site, to the site of administration, including the hospitals, to the roll-up of all that data back to the state and government and federal government. And so this process is something that we are now recognizing is going to have to be coordinated through a central platform, which gets us to kind of the second topic, which is the platforms that we're seeing that allow us to be able to leverage cloud, interoperability, care coordination that will enable these vaccinations to be done more efficiently, enable better care, more personalized, individualized care. I've given you snapshots or individualized stories on how all of this works. But what we're at a high level, and again, if you take a look at maybe what we'll start is that maybe we'll call it a pie in the middle, that upper left-hand part is about understanding the individual. If we can get the data that is specific for that individual, understand their situation, similar to what we did with the COVID bot. We know the specific pieces of information that's relevant to you. We can provide an individualized recommendation. We can apply, if we go to the lower part, an AI-based chatbot to drive the insights, apply the protocols, and provide direction. Now, if it turns out that if we move up to the upper right-hand quadrant, there needs to be a care coordination element. You're going to do a handoff to a team's virtual visit. This also needs to be tied together. So literally with some of the examples, like the bot example, where we're providing personalized care, driving the insights and what needs to be done, and then coordinating it through a team's, allows us to be able to then stitch together those clinical workflows where data is at the center, and allows us to be able to create a platform, a cloud for healthcare platform that will be enabling personalized care, empowering the teams, ultimately improving the health outcomes, and at the same time, allowing us to do it in a secure manner that's transparent and creating new workflows associated with that. So to give you an idea of how this is now being deployed, this new digital platform that many organizations are starting to look at. One of the things most recently in the United States, what we launched is the Microsoft Cloud for Healthcare. In fact, we announced it, I should say, a few months ago, and the launch is at the end of this month in October. One of our partners, the Cleveland Clinic, has been working with us, and we also have several others that have been looking at different use cases and applications. And so let me share with you just some ideas and some of like what people are thinking and how we're looking to apply a digital platform that goes across the care continuum. And I'm going to start with a personal story. I'm not sure how many of you are of this age, but I'm at the age where it's appropriate that I receive a screening colonoscopy for colon cancer. Now that is a procedure that sounds pretty straightforward, but just getting it scheduled was a challenge. I needed to do this during the pandemic, so didn't get scheduled right away. In fact, it took 4 months before I actually got it on the calendar, largely because things were shut down initially, and then after a while, it was up to me to keep on calling and finding out when things are back up. Well, once it got scheduled, all the initial prescriptions that were sent to the pharmacy had expired. I had to actually go back. I went to the pharmacy. They said, sorry, you're gonna have to contact your physician. So contacted the office. They had to redo the prescriptions, went back and got them. Now, I had received instructions early on in what needed to be done. I didn't get a new set. I just, because it was all still part of that same journey. But even though 3 months had passed, I had to look through my inbox to figure out what exactly I needed to do. Well, it looks like there was some pretty important information in there. I needed to stop my medications, specifically aspirin, a week before. I needed to take this Go Lightly, this completely 2 days before, and complete the prep. I needed to actually take a COVID test. They asked me 3 days before that or a week before that I need to get this test, and there was no flexibility. I had to get it 3 days beforehand. So all of that was on me to schedule that. And if I had missed any one of those, this procedure would have been canceled. And that just is an example of how the systems that we create are not patient-friendly. They're very burdensome. In fact, most patients will slip through the cracks because something's going to happen. You're going to forget something, and that leads to inefficient care, worsened patient outcomes, and in many ways, dissatisfaction with the overall system. And so what we found is that the way that we have to start thinking about this is not just we need to send a digital reminder, but we need backups. If a patient were to forget or not be able to do certain things, we need to know that this is a patient who's at risk. Perhaps maybe this is an individual who has missed the last 4 appointments. They're probably at higher risk for not showing up again. We're going to have to be particularly attentive. Just prior to them stopping the medicines or starting the medicines, we need to make sure they fill that prescription. Somebody should call them. We need to start thinking about using all our individuals across the care team and empowering them with information. I'm talking about the call center agent. I'm calling about the receptionist. I'm talking about the case manager. I'm talking about the visiting nurse. All of those people need to know that this is the person who has to have this procedure done by this date with these particular types of tests, and they are all working together to do the things that need to be done. And how can that be done? We can pull all that data, run it through AI algorithms like chatbots, and provide scripted questions back to non-physicians, non-nurses, non-clinicians, back to the patient to ask. It's just simply, did you get this? Did you need help? Can I direct you to this or that? And ensure that the patient is actually on their journey. And we can do the exact same thing post-procedure. Patients can be sent home with bots that allow us to be able to assess whether or not they're taking the medicines or have any questions. What we can then do is we can have follow-up with that, with virtualized consults, but also even remote patient monitoring. And as we thought through that process, the amount of data that we have today that we can leverage to be able to do the types of things I'm talking about to get that 360-degree view is tremendous. If you look at the left-hand side, it's not just electronic health record data. We now, within the Microsoft Cloud for Healthcare, what we did is we had to, because EHR data was so important, we had to build a FHIR API using open APIs to pull data into the system. You can also do that through just an HL7 feed. Imaging, that was another area. So we just recently launched a DICOM server that allows us to be able to bring in images and then potentially search through those images based on metadata. Genomics, third-party data. Third-party data is like social determinants and social influencers of health, transportation, medication issues. And then IOMT, Internet of Medical Things, or remote monitoring devices. All of these devices that I mentioned wearables, I mentioned patches, all of that could potentially now be captured and brought into a common platform, which allows us to be able to normalize that and then analyze it using artificial intelligence, and then deploy that in the context of teams for collaboration or dynamics for a case manager or for a call center agent to reach out to them, and dashboard it out through Power BI tools. And so all of this now is an integrated system that allows us to be able to reimagine and rethink what's possible. And as we've been thinking through this, one of the key use cases that we've run into, let me see if I can advance the slide here. Oh, looks like we stalled here. Is through the use of Teams that allows us the ability to do all those different things I mentioned. I'm not going to go into great detail because I talked on many of these, so let me just, for the sake of time, skip over to the next component, which is that now this information that's being captured, it could be captured through text message, it could be captured in the form of a progress note. That's another piece of information that we can also bring into the mix. But in order to do so, we have to format and restructure that. And what we've been doing is building tools that can take text, free text, and form and understand the concepts. So this whole ability to use artificial intelligence to do text analytics to allow us to be able to understand what free text can be relative to a particular symptom, sign, and organize that and present that is allowing us to sort of rethink a couple of different possibilities. One, in patient care, if we pull all that information through text or progress notes, we can do screening for things like depression in seniors or even anyone with loneliness. We can assess for substance abuse. We can assess for suicide risk. We can assess for medication noncompliance. We can assess for multiple different aspects of care that oftentimes get missed by looking at the data using text analytics. Similarly, if we're a clinician and we're trying to provide the right study or the right drug, and we're in a tumor board, we can run this and identify the studies that have done. So looking through the abstracts and actually understanding, I want to know which drugs, which chemotherapy regimens for this particular, with the genomic profile of this, are most effective for mortality. You can pull that type of information up. So we're realizing that the text analytics piece is this huge opportunity. And on the topic of natural language processing, one of the other exciting innovations that has not only been developed, but now is just launched, or actually will be launched in the next couple of weeks, is voice AI. And so as part of that, what Microsoft had been doing is working closely with a partner called Nuance. We built a voice AI technology such that the conversation that the patient has with the doctor, the natural conversation we have during an interaction, is captured from and translated from text, I should say from free text into a structured, so it's a voice to text, I should say. And then from there, it's organized in a way that allows us to be able to understand the context of it. And then it's codified and brought into the medical record. So literally the conversation we're having, brought into a format, you take the final review of it, push a button, and it brought into the medical record. Extraordinary technology. It's actually been shown in the early pilots to have a 50 to 75% reduction in the documentation time for clinicians to document in the electronic health record, and a physician improvement in the physician satisfaction by 88%. So the huge benefit in terms of what some of the challenges that we're seeing today. And lastly, I'm going to close, and then we'll open it up for Q&A with the topic on the digital transformation we're seeing around patients. There are so many different new sensors and things. And if we were to think about what we have today versus what we had 10 years ago, what we used to use was maybe a fitness tracker, perhaps maybe would be the most. We now have digital weight scales, blood pressure cuffs, we have EKGs, we have even implantables, we have continuous glucose monitoring, and the list goes on. Now that information can be tracked, it can be reported on a regular basis, so you can see this for individuals, and we do this on a regular basis, but the problem is this is just too much information for clinicians. They don't have time to look at all this for every single patient. So what we really want to do is we want to be able to draw the insights from this. And the best way to do this is, rather than just simply looking at the individual on a one-by-one basis, look at cohorts of individuals, patients like you. These are individuals that have a certain age group, risk factors, demographics, and then predict out what those trajectories are. And then in so doing, it allows us to know who needs to be acted on earlier. And this is the type of information that clinicians are looking for. They don't want to know all the information, all the number of steps and the heart rates and the EKG patterns. They want to know, who do I need to act on, who's heading in the wrong direction, and how can they act early? And this is the opportunity for us to be able to rethink healthcare. We've got so much data out there. The platforms now are becoming much more nimble, scalable, secure, and with the technologies, with the care coordination, with the ability for us to be able to deliver this in a manner that's efficient, we have an opportunity to allow for organizations to reimagine healthcare and deliver better care. So with that said, I am going to close and open it up to questions. And Alexander, maybe I'll just hand it back to you for now.
Thank you, David, for the exciting keynotes. I believe that this was mostly a masterclass, and in this idea that we have a brief follow-up with what technology meant in the last 9 months, 10 months, and also what will happen in the near future. We are open to questions, so you can put your questions on the platform so that I can introduce them to our keynote speaker. But mostly, I have some small questions. Actually, we don't have so much time. We have something like 5 minutes. But David, what do you believe that are the most relevant technologies that are going to be used in the near future? You talk about the relevance of chatbots. I was quite interested. In Europe, we actually don't have so much experience. They were somehow considered as medical devices and are not, well, at least accepted as something that could be used. You mentioned also the relevance of AI and Azure, the technology from Microsoft. Actually, I know that in Israel, for example, all the data is in the cloud, available for startups to use and to develop further technology. What do you think it's the most low-hanging fruit on technology for tomorrow?
So I'll talk about tomorrow and today because I feel like what we found with some of the things that we've developed, we have potentially some industry transformative technologies that we are just embarking on. And let me start with the voice technology. I mentioned this earlier. Ambient clinical intelligence, the ability to take the conversation that we have, convert that from voice to text, understand the context, put it into a structured note, and then bring it into the medical record. That's just the beginning. Once we actually understand the context, then we can apply the artificial intelligence on top of that, and then look to see whether or not we've got quality gaps, safety gaps, reimbursement gaps. There's nothing more frustrating for a patient and a physician than to find that your claim was denied because you didn't order this X-ray or you didn't order this lab test. I mean, we want to know that up front. That's the type of stuff that can be beneficial for the efficiency, but also most importantly, right now clinicians are burned out. There have been studies that have shown that over 50% of physicians are dissatisfied with their healthcare. If we lose our physicians, we lose our nurses and our pharmacists, we don't have a healthcare system. So we need to start thinking about how do we make things better for them. And then at the same time, there are tools for patients that are completely transformative. We need to think about the patient experience. It's not just about enabling data to be captured. It's about improving one's lifestyle and the quality of life. If we were to implement, let's say, tools that help seniors live independently at home, allow us to be able to create systems that address the whole aspect of one's care. Because a lot of times we look at it and go, well, the hemoglobin A1C is looking normal, but the reality is they lost their job, they don't live and have a home. We don't realize that that's a patient who probably a month from now is going to come to the ER because they are in DKA and didn't have the insulin, because they didn't have the refrigerator, because they didn't have the home. Well, these are all things that we could predict. In retrospect, everything's easy to predict, but we now have the data and the AI to be able to do those predictions. And so by looking holistically at patients, looking at everything from their zip code to what their history is, to their current problems, we can run these AI algorithms and then allow us to be able to have targeted interventions. That's going to lead to better population health. And as we think about what we want to do, it is individualized care, but it's also large scale, at scale. And that's why AI has such a huge opportunity for us.
Thank you so much, David. Our time is elapsing. I must say that thank you so much. I must say that also in the last months, Microsoft has been quite used, mostly with Teams, not only in the work of our clinicians, but also administrative staff, and also even used in medical appointments. So Microsoft evolved a lot in the last months. I know that you continue to support technology and development of healthcare, and thank you so much for your fantastic keynotes. We will continue to work on the future, and thank you so much. I know that it's early morning in Palo Alto, so thank you so much for being excited at this hour and to give this wonderful presentation. Thank you so much.
Thank you. Appreciate it.
Bye.
Bye-bye.
Bye-bye.